So next is hemostatic agents. It's V14. A patient on warfarin presents with fresh rectal bleed and INR of 8. How will you correct his INR? If patient is hemodynamically stable, only has a small rectal bleed, I would treat the patient with 1 to 3 milligram IV vitamin K. IV dosing works more quickly than the oral, and the INR should return to normal within 6 to 8 hours. Large doses of vitamin K can make re-anticoagulation with a warfarin difficult. If the patient is unstable, has loss of blood, I would contact the hematology, and patient will need prothrombin complex concentrate at 25 to 50 units per kilogram. Warfarin reduces the levels of 2, 7, 9, 10, and PCC rapidly corrects it within 10 minutes. The factors have a finite half-life, so 5 milligram vitamin K is given at the same time. I would recheck the INR 30 minutes after giving PCC and every 6 hours thereafter with the frequency determined with the severity of the bleeding. If unvaccinated PCC4 is not available, then unvaccinated 3-factor PCC can be given, but it should be covered with the FFPs. Administration of FPCC is preferable to FFP because FFP has a dilute concentration of clotting factor that is difficult to infuse large volumes rapidly and produces suboptimal anticoagulation reversal. A patient on a direct oral anticoagulant presents with a fresh rectal bleed. How will you manage him? Again, if the patient is hemodynamically stable, has small rectal bleed, I would withhold the direct oral anticoagulants and monitor the clinical status and recheck the lab, including coagulation. If patient is unstable, then has a loss of lot blood, I would withhold the drug and give activated charcoal if it was taken in the last few hours. Then I would contact the hematology consultant on call. If the patient has taken the thrombin inhibitor, that is factor 2 inhibitor, that is dabigatran, then we can offer him idarucizumab. If idarucizumab is not available, then the patient needs a prolonged hemodialysis to get rid of this blood from the circulation. If clinically significant position, further treatment is required. This is the same as that for the factor 10 inhibitors. For major bleeding that requires reversal of anticoagulant within 24 hours, the patient requires PCC. For major bleeding that requires reversal of anticoagulation within 1 hour, the patient requires either unvaccinated PCC and further doses or low dose activated PCC. So, if it needs to be reversed in 24 hours, then the unit is 5 units per kg. If you want to reverse it in 1 hour, then the units are 25 to 50 units per kg. It's also important to identify and treat. It's also important to identify and treat the cause of over anticoagulation. You're doing a trauma laparotomy on a patient who has been stabbed in the abdomen and has several lacerations to the large bowel mesentery with mesenteric and retroperitoneal hematoma. All the vessels have been tied off or cauterized, but the patient is still oozing. What else can be done to control the bleeding? Firstly, I would liaise with the anesthetist. Is the patient hemodynamically stable? And are we approaching damage control situation? I would check the full blood count and coagulation parameters and ionized calcium. I would use the thromboelastogram to guide the transfusion of FFP, cryopresin platelets. If necessary, I would instigate the massive transfusion protocol. To control the interval bleeding, there are 3 further options: hemostatic drugs like tranexamic acid, topical argon beam coagulation, and then topical hemostatic agents. So what topical hemostatic agents you could use? So there's a lot of topical agents like biological active agents, topical thrombin agents, avithrom, and then bovine albumin glutaraldehyde tissue adhesive, bioglue. Glutaraldehyde forms covalent bond with the protein of the extracellular matrix of the target tissue. This produces a flexible mechanical seal. This reaction is independent from the coagulation pathway. Fibrin sealants or glue like cross seal, gelatin or thrombin sealants, flow seal, and then is the dry matrix agents. Then is the microporous polysaccharide spores, then microfibrillar collagen, avitine, then oxidized regenerated methylcellulose, Surgicel. What hemostatic drugs are available? It's desmopressin and tranexamic acid. Desmopressin is a synthetic vasopressin analog. It stimulates the release of factor 7 and 1 billion factor from into the plasma. And tranexamic acid inhibits the conversion of plasminogen to plasmin and impairs the fibrin dissolution. It is recommended for trauma patients with or at risk of significant bleeding, where it significantly reduces all-cause mortality. Loading dose 1 gram infused over 10 minutes within 8 hours of the injury, followed by maintenance dose of 1 gram over 8 hours. Crash 2 randomized controlled trial. And then is A-protein, which inhibits circulating plasmin, thrombin, and regulated protein C, and recombinant factor 7A, which is used in the it enhances the coagulation. It is used with hemophilia. Thank you.